So what I'm going to cover in this lecture, I'm going to talk a little bit about generating a differential for supratentorial tumors based both on age and location, which I think are the two biggest pieces of information that will get you to a very good differential and almost to the diagnosis in some cases. And then I will also talk a little bit about integrating advanced imaging techniques, because it always seems to be what people are interested in. And then also talk a little bit about some of the genetics and molecular alterations that we see in supratentorial pediatric tumors, because there's been quite an explosion of this in our literature, and I think it's important as neuroradiologists for us to understand some of this. So I'm going to start with the babies. Neonatal brain tumors. Essentially, if you're reading and you hear about a case that's a congenital brain tumor, without even looking at the images, 50% it's going to be a teratoma, and that's pretty much it. And then and that's right at birth. Now, what's interesting is that if you go into the first 2 months, though, that 50-50 teratoma differential actually changes, and the percent of neuroepithelial tumors actually goes up. So just within that 2-month period, you actually have a change in the prevalence of these tumor types. In terms of the neuroepithelial tumor types that you can see that are in the neonatal period, they include medulloblastoma, which is obviously posterior fossa, but also choroid plexus tumors, ependymoma. You can also see craniopharyngiomas. So here's a case. And so actually when I had read this case, I thought, oh, it's a teratoma. And it's suprasellar, it's got a lot of heterogeneity, there's cysts on the T2, it's very, very heterogeneous. What was interesting, though, is because of shunting purposes, they actually did a CT, and you can see that there are a lot of calcifications. I still called it a teratoma, but I was wrong. It was actually a congenital craniopharyngioma. So if I saw the case again, I probably would still say teratoma. Anyways, so the next case I want to show you, because this is just an interesting one. This was a newborn that also had an abnormal cranial ultrasound from an outside institute, and they sent the baby for an MRI. And immediately the tech started getting the T2 images and called me over and said, there's something not right. And I started looking at the axial T2, and I'm like, yeah, you're right. There's something wrong. There's something really wrong. And I was thinking, it looks like a duplicated cerebellum with, it's got to be that. I don't know what this is otherwise. And of course, none of the senior people are around, so you're like trying to figure this out. I did give gadolinium. It did enhance. But I also wasn't sure where it was coming from. And that's really important. You have to know kind of where the tumor is sort of coming from before you really figure out the differential. So I don't ever do a sagittal flare in a baby. I did in this case because I was worried that it was coming from the suprasellar area. And on the flare, you can see that it's actually coming from the tuber cinereum. And that case was actually a giant neonatal hypothalamic hematoma. They're pretty rare, but it was sort of their approach. I also did spectroscopy. I didn't put the slides in, and the spectroscopy of the lesion was similar to gray matter. So a lot of times, you may use these different types of techniques to sort of figure out where the tumor is coming from, and you can still, make a diagnosis, hopefully. But that was kind of a weird case. So now we're going to go to the older kids, and what we see more commonly are supratentorial lesions in the first 2 years of life relative to the posterior fossa. And then that differential changes as we go to older kids, and it's about 50-50 supratentorial and posterior fossa. So what I'm going to do now is just go through different regions. I'm going to sort of switch from the age thing to the location and talk about different locations. And start with pineal tumors, this being just sort of a list and differential. And this is all in the syllabus, so you don't need to write any of this down. So starting off with CT, it's always the first-line imaging, even though we try not to do it as much. Calcifications and hyperdense tumor. The hyperdensity usually suggests hypercellularity, and the location here, most likely this is going to be a germinoma. You don't even need the MRI, but we still do the MRI anyways. And on MRI, we see that the T2 signal is low. That correlates with hypercellularity. We can see the hydrocephalus and some of the transependymal edema. And if we look at the diffusion, there's diffusion restriction. So hyperdensity on CT, low T2 signal correlates with restricted diffusion or low ADC. And that alone gets you by with a lot of different tumor types if you just understand that. Now, of course, I do spectroscopy. I put voxels on different lesions, and sometimes it's helpful, and sometimes it isn't. What I have found with when I was working at LA Children's, I worked with Jonathan Finley, who had a huge population of germinomas that were coming around the world to see him. So I had a lot of opportunity to see different types. I don't actually see this now in Pittsburgh, but I actually did do some spectroscopy on some of these different germ cell tumors. And the one thing that I found, if you do short echo, they do have taurine. It's very similar to medulloblastomas, which makes sense because they're sort of that PNET, round blood cell type lesion. And so now, as opposed to mixed germ cell tumors, usually you can't get a very readable spectra because you just get a noisy spectra. There's not a lot of meat in the tumor to actually get good signal to noise. And so that's one differentiation that I have found between mixed and pure germ cell tumors, if that's important. Teratomas, you can get signal, but you don't tend to see taurine. And so that's been my experience with doing spectroscopy on different types of pineal germ cell type tumors. Now, I've had cases where there's a lesion near the tectum going into the pineal area. Is it really a tectal abnormality, or is it really a pineal abnormality? And I have used spectroscopy to look at some of those lesions. This doesn't come off that often, and this is just an example of doing a spectra on a very small lesion and seeing a lot of NAA. I don't see taurine. The choline to NAA ratio is increased, and this was consistent more with a astrocytoma over a germ cell tumor. Now, in terms of treatment, we know that most of these patients are going to get chemotherapy, they're going to get radiotherapy, and then you end up following lesions for a long period of time. They're usually calcified. You don't usually see changes. Occasionally, there may be subtle growth, and then there's some need for the neuro-oncologist to figure out what's going on. I have tried to do spectroscopy. It's really, really difficult because usually they're calcified and you can't get good signal to noise. This was just one example of a case that I did for Dr. Finley, trying to figure out was there scar tissue or residual germinoma. And it was difficult. I couldn't see a lot of NAA. There was some choline. I couldn't be definitive, and it turned out this was scar. So sometimes you just you're limited. You just can't always apply some of the advanced techniques. This was an interesting case, bilateral retinoblastoma with a pineal lesion. What I have found useful is always look at the T2, because sometimes on contrast, a pineal cyst can fill with contrast and look solid, and you really need to confirm that on T2, especially if you're going to send them in to actually take the lesion out. This was an example of a triretinoblastoma. This is an interesting case. The patient came in with hydrocephalus. You can see in the pineal area that there is a CSF abnormality that looks almost like an arachnoid cyst. On the MRI, this was definitely looking like an arachnoid cyst, but luckily I saw the diffusion images, and on the diffusion it was markedly bright, and this is consistent with an epidermoid of the pineal area. What's also useful is they do surgery, and you're actually following the diffusion. Sometimes can pick up the residual or recurrent epidermoid, so it's very useful to do diffusion imaging. This is another case. I am still in the sort of germ cell tumor abnormality spectra, just to give you a hint. This actually came in. It was concerned that this was a pilocytic astrocytoma. But if you look at the lesion, the solid area is hyperdense. It's not hypodense. So that would be a little atypical for a pilocytic. And then on the imaging, you can see some fluid levels in the cysts. It's very well circumscribed. It doesn't have a lot of edema around it. And you can actually see the fluid levels on FLAIR, and this actually turned out to be a basal ganglia germinoma. They're rare; it's not a typical location, but when you see it, it's actually fairly diagnostic. And on the diffusion imaging, you will see that there's restricted diffusion in the areas that are solid. It's hard to do spectroscopy because you just don't have a lot of tissue to go after. Now I'm going to move to the interventricular tumors. This is just a differential. It's in your syllabus. In terms of papilloma and carcinoma, typically the carcinoma, choroid plexus carcinoma lesions are larger, they're more invasive, they have more edema around them, and so they're usually fairly easy to distinguish between papillomas. You can do spectroscopy, and on spectroscopy, usually the papillomas, if you do short echo, will have higher levels of myoinositol relative to the choroid plexus carcinoma. Where it gets tricky is if you have atypical papilloma lesions, and now I've been doing this a longer period of time. I've had some choroid plexus atypical papilloma cases that have this different type of histological designation for atypical choroid plexus papilloma, and the myoinositol is slightly elevated, and so you could still get yourself in a conundrum with using spectroscopy if you get one of those atypical choroid plexus lesions. This is an interesting case. This was a sibling that, two siblings, the brothers is on your left, the sister's on the right, that had the P53 tumor suppression mutation in their family. And the younger brother had a choroid plexus carcinoma, as you can clearly see. But the sister was screened, having Li-Fraumeni and the P53, and we saw this lesion in the choroid plexus that was small, not particularly big, and we were worried, is this a papilloma or a carcinoma? And, she's a healthy 8-year-old. Do you really want to subject to surgery or just watch? So we actually did a 25-minute spectroscopy, so you bump the signal average up really, really high. And from that, we actually we felt the spectra was more consistent because the myoinositol was lower with carcinoma, and so they resected and it was a carcinoma. So I do think that there may be some value of spectroscopy to help as an additive tool to what you're thinking in management. Freeman-Monroe lesions is just an example of a SAGA, and a typical look to a SAGA in the setting of tuberous sclerosis, where we see the calcified glial nodules along the ventricles. On MRI, we can see the hamartomatous lesions in the cortical areas in the setting of tuberous sclerosis. Now I'm going to turn to the suprasellar, infundibular, and sellar region and just go through a couple of cases. Pituitary macroadenoma is pretty standard and in terms of how they look. In terms of infundibular masses, there's a differential, which includes germinoma also, as we talked about before, but also histiocytosis, lymphocytic hypophysitis, other differentials. What I wanted to do, though, was sort of talk a little bit about if you have certain suprasellar lesions, sometimes they're fairly pathognomonic, but other times they actually can be difficult to distinguish. And usually you're thinking about glioma, germ cell tumor, and craniopharyngioma sometimes. And these, I just listed here kind of the things that you look for to actually help distinguish them, because the other imaging characteristics are fairly, they tend to overlap. So this is an example of a very classic-looking optic pathway glioma in the setting of NF. You can see that the lesion is going along the optic tract in terms of the growth pattern, which helps you determine that it is an optic pathway tumor. Now, while what I wanted to do at this point is actually talk a little bit about genetic alterations, because our field is seeing what I think is a really big change in how we're going to see some of the pilocytic astrocytomas managed. And it comes down to just some recent findings in relation to a particular mutation called BRAF, which has been shown to be very prevalent in low-grade tumors. This is in your syllabus, so you can certainly pull the paper and read it. Essentially, this BRAF mutation, it is associated with downstream activity, including kinase activity, and it basically has different types of pathways that are downstream that can affect ultimately low-grade glioma cells. And the advantage of that is that it gives you a multiple target approach where you have different different pathways that could be potentially targeted using a particular type of agent to counter that particular pathway. And in this case, the BRAF leads to MEK, which is MEK, which leads to ERK, which is ERK, and this is all part of that pathway, which has been now delineated in detail in low-grade gliomas. And this, the next step, has led to clinical trials. And these are a list of just some of the clinical trials now targeting each of those different pathways in relation to the BRAF mutation, including MEK inhibitors. In our own PBTC work, with Tina and other investigators who are involved with the PBTC, there is an ongoing study, which is the AZT-K244, or the MEK inhibitor study, looking at some of these pathways. And I'm just going to show an example that Dr. Jakak, one of our oncologists, gave us of some of the responses that we are seeing. And this is something I think we're going to see more of that have been very promising. What's been interesting about it, there are some new challenges because there's residual non-enhancing tumor left, and it's not always clear exactly how to really understand if the tumor is still responding or not. So I think we're going to see, while this is very exciting, we're actually going to see some new neuroimaging challenges emerge from this and up in the future. So definitely keep an eye out for this. In terms of spectroscopy, if you use short echo spectroscopy, you can actually you can diagnose pilocytics, and I'll tell you why. Usually they have very noisy spectra at baseline because they're hypocellular tumors. And if you use LC model or some sort of a program to help you quantitate the metabolites, they're usually very low in concentrations across the board. And so it's an example of where using quantitative spectroscopy can actually help you with the diagnosis. But you have to be familiar with how to use LC model. The other hallmark to these tumors is that they have a very low creatine peak compared to the choline peak. But the overall concentration of all the metabolites is very low. So if you actually calculate the total concentration of choline, it's actually very low. You see a really big peak next to you there, but the concentration is very low compared to other tumor types, which makes sense. So if you have a case and there's a concern, could this be a pilocytic? If you do the short echo spectroscopy, but then quantitate it with LC model and look for low concentrations, you can actually make the diagnosis. Now, what's interesting is that how I've been looking at the spectroscopy has even evolved. I had always thought this peak that I'd seen with the supratentorial pilocytics was NAA, but Stefan Blumel is a spectroscopist that I'm working with still, who's at LA Children's, has decided that is not NAA. It's a molecule called NGAL, and he's figured this out from doing a lot of 3T work. It never quite looked like NAA to us, and what does this mean? I have absolutely no idea, but it's interesting how your observations can certainly change and evolve over time, and maybe there'll be something interesting that we find. This is a patient who's being treated with multiple recurrent lesions and a diffusely metastatic JPA. So you can actually get pilocytics that are very diffuse and will metastasize and act very aggressively, even though it's a fairly non-aggressive tumor. And this is one that we actually treated with a peptide-based immunotherapy protocol that actually responded really well to the protocol. Now, getting back to that differential on optic lesions, this is a patient that was referred to us for treatment of an optic pathway tumor. And if you look at the chiasm here, it's thickened. It does really look like it could be an optic pathway glioma. However, when you look at the T2, there's some atypical features. The T2 signal is very dark. There's also these sort of funky little cysts that are coming right off the top of the chiasm toward the hypothalamus. And you see dark T2 signal that could suggest the possibility of hypercellular tumor. Now, what I have here is this was the scan that was the post-contrast imaging for the T2, relative to the T2 images that I had just shown you. And the outside study, this was actually missed. There was a small subependymal nodule. And so the one thing that I always tell my residents and fellows, when you read any follow-up on a germ cell case, you have to look at the ependyma. That is usually where they tend to metastasize to if they don't, beyond recurring in the primary area. And so by the time the kid actually came to us with that diagnosis, this is actually enlarged. And this was a supracellular germinoma with a ependymal metastasis to the frontal horn. Craniopharyngiomas, this is a classic look. Rim calcifications nail the diagnosis. And so if there's any concern and you have a CT, you can usually make that, and you can usually see these on SWI and also on gradient echo imaging. However, craniopharyngiomas can have a solid look also. They tend to be in older patients, and this is just an example of a solid craniopharyngioma. Now I'm going to talk a little bit about the embryonal tumors, and there's been some change a little bit in terminology, so I wanted to, in the literature, in terms of how these are classified and labeled. The CNS PNET refers to a spinal cord PNET, brainstem PNET, posterior fossa PNET that's different than medullo, and then also supratentorial. So in theory, you can actually get a PNET in the posterior fossa that's not medulloblastoma. I haven't quite seen that yet, but that in theory you can get that. ATRT and medulla are the other type of embryonal tumors. So I did do a literature search, actually trying to see how much has been written on supratentorial, and I ran across this paper by the Toronto group that was from 30 years ago, and they had made some very, very marked observations about the hyperdensity of these tumors on CT. And essentially, they looked at 30 supratentorial PNET cases, so it's actually one of the largest collection of cases. And the two hallmarks were hyperdensity on CT and very large lesions. And even now, in my current cases, which I actually don't have, I have maybe like 3, you see the same thing. They're very large lesions, they're hyperdense on non-contrast CT, and they restrict diffusion and on ADC imaging. And so this is a fairly classic look for a supratentorial PNET. Now, this is where things have changed a little bit in terms of terminology. There's really 4 different types of embryonal tumors that fall in the spectrum of supratentorial PNET. And there's this term out there now, which I actually just heard last week, so I thought, I should share this with you guys. Embryonal tumor with abundant neuropil and true rosettes. You're going to start hearing this. This is a subtype of what we used to think were just supratentorial PNETs, and it's a histological subtype. Medulloepithelioma is another subtype. Supratentorial PNET is one, and then if you see it in the pineal area, pineoblastoma is the differential. But why is this important? And this was also something I saw just last week that a neuro-oncologist gave a talk, and I was dying to get this, and luckily they had published it. So, and what this shows you is that a lot of these genetic and molecular alterations that are found histologically or through genomic studies are dictating how therapy is going to happen. So the top one is I'm not talking about the posterior fossa tumors, but medulloblastoma now has 4 classifications that can actually dictate how they're going to be treated. But the supratentorial ones now, PNETs, actually have classification based on the ETANR-TR that I told you, and then also just being a supratentorial PNET. And so it is going to be important to understand some of this terminology so you can be part of the game when you're at a tumor board and talking to your clinicians. Now, ATRT is different. That's actually diagnosed with INI1 staining. It has, however, imaging features that overlap. They tend to be a little more heterogeneous. This is an interesting case because on the spine imaging, there was a lesion by the kidney, and so you always have to be really careful to look at your body parts when you're reading those spine cases, and this was an example. Luckily, I did see this, and we got a CT, and there was an associated rhabdoid tumor of the kidney. So, so those are ATRT lesions. I'll briefly talk on some of the ganglion cell tumors, which include DNAT ganglioma. This is a classic look for a DNAT. It's a well-circumscribed T2 hypertense lesion, tends to be cortical, can cause some inner scalping, and usually not enhancing. It has septations in it. It's a pretty classic look. Now I'm going to spend the rest of the time just talking about different types of astrocytomas and get into a little bit about the genetics and some imaging, advanced imaging work. And this slide here just shows us a little bit about how therapy has been failing miserably on the high-grade gliomas. So the blue is the brainstem gliomas, which are just even worse prognosis, and the therapies aren't working at all. But compared to our adult colleagues, our high-grade gliomas in kids are not, the therapies are still not effective. And this is in the syllabus. There's been a lot of work now in terms of some of the genetics and molecular alterations. The IDH mutation that you hear a lot of in the adult, that doesn't really seem to pan out as much in pediatric patients. Also, the high-grade tumors that we see in pediatric patients are very different molecularly and genetically compared to the brainstem glioma, pontine glioma, even though they have similar dismal outcome rates. And so those are just some sort of important things to understand. Now I'm going to get a little bit into some of the advanced imaging, and because this is where we've been using these techniques mostly in these high-grade tumors that are on complicated treatment protocols. And this is just an example of the many different types of advanced imaging that we can apply. And these are sort of the challenges, especially with targeted therapy. We're seeing more pseudoprogression. Treatment-related heterogeneity is sort of an overall encompassing terms that the adult use, and that's related to complexity in the types of necrosis patterns, seeing one part of the tumor responding while another part is actually progressing. And these are all things that where we turn to advanced techniques because the conventional imaging doesn't help us. Now, in terms of spectroscopy, if you do short echo spectroscopy, when you get an increase in choline, that does tend to correlate with higher grade. But my experience with spectroscopy is that there is a lot of overlap, especially in the grade 2 to grade 3 in NAA in choline to NAA ratio that does limit what we can do with spectroscopy. And just to show you some examples, this is an example of short echo spectroscopy in an anaplastic astrocytoma. And in one case, you can see the choline to creatine peak is almost identical in height. And in this case, there's a marked difference in height, and these are both grade 3. So this is why I show this case, is because you can't always nail the diagnosis with spectroscopy. It has limitations. This is an example of a bithalamic astrocytoma that we've been following for months, where the choline to creatine ratio is fairly high, but there's been stability over time. So and then this is an example of a bithalamic astrocytoma that had actually very similar choline to creatine, but did progress in a much more short period of time and had low perfusion at diagnosis. So a lot of the things that we see in the adult literature where high perfusion, choline to creatine ratio, all these things can predict regressive behavior, I don't think work all the time or very well in pediatric subjects. We did find, though, this is actually a citrate peak, and we did find in some of our research that if you see a citrate peak, that can actually predict aggressive behavior, but that's still being worked out. What I find useful when looking at treatment cases is whatever you do, just be consistent. So whether you use short echo, long echo, multi, or single, you have to be comfortable with interpreting on the fly and then making sure you put the voxels in the same location when they come back so that you can see changes over time. That's the bottom line. As long as if you mix and match your techniques and you're not putting the voxels in the right location, you're not going to be able to it won't be very useful. But serial imaging does have a lot of use, and you can, with single voxel, you can get good specters. Multi-voxel is a little bit more complicated. Perfusion imaging is a lot easier, so I think it's gotten easier over time. I just want to briefly show you some examples of immunotherapy response. This is just a study that we have ongoing in Pittsburgh that has developed, Dr. Pollack developed a vaccine that's injected subcutaneously that has peptides that target pediatric glial proteins in the tumors. This is an example of one of the cases that we have a recurrent glioma where we actually did see a response with the vaccine peptide vaccine study. And other type of patterns that we've seen, however, we've seen some cases where you do see a response, but contemporaneously or almost around the same times we'll see recurrence in different locations. And this has been very challenging in terms of what do we do, how do we treat this, and I think we'll see more of this with some of the targeted therapies. We've been looking a little bit at ASL. It's actually fairly easy to run and quantitate depending on which vendor you have. The GE one is actually the easiest to run, and it's easy to read. The map is generated at the scanner, but you can also quantitate and look at changes related to ADC. We've been finding that lesions that tend to be recurrent have an inverse relationship between ADC and perfusion, which makes sense in terms of the cellularity and hypervascularity, compared to lesions that are stable. In terms of lesions versus vasogenic edema, we don't see the same kind of response in vasogenic edema. And these were all done with just a region of interest measurement and also ASL, which was all clinically acquired. I'm going to just sort of end really quick on some interesting stuff that's sort of out there. Sodium imaging is some work that I've been involved in, where we've been using sodium imaging to see if we can predict changes in perfusion, in tumor behavior in relation to proliferation. Tumor concentrations are related to mitosis, and that is indirectly related to the flux of concentration of sodium between the intracellular and extracellular compartments. This is an example of one of our cases that was on the immunotherapy protocol where there was a concern for pseudoprogression on one of the follow-up scans, but the sodium is really nicely showing a response. And so I think there's some value to this. We're still trying to figure it out. In another patient here, this was a patient where you saw the recurrence in the response in one lesion, then the recurrence in the other. In this case, the sodium did not predict the recurrence, so it wasn't useful to actually show the lesion before you could actually see it on the conventional imaging. We've been using dual echo now to actually look at intracellular concentration of sodium versus total concentration, and have been finding it to be somewhat useful to look at both responses. An example where you can see the response and the change of the tumor progression over time in the bottom row on the sodium before you actually can see it on the conventional imaging, but also looking at response to therapy where you can actually see changes in the intracellular sodium concentration without much change on the flare. So this is all work that needs to be figured out. We've also been looking at multi-band MR spectroscopy, because one of the challenges we have with the multivoxel is the length of time it takes to run. But with multiband technique, which is similar to the DTI multiband, you can actually run these in a few minutes. And I think this is technology that's going to be coming out. We've also started a 7T project on our older T kids to look at specific metabolites. And this is just an example of a 7T spectra. So just to wrap it up, and maybe this will be helpful for your SAM questions. In terms of, I talked a little bit about age and location, how that's important to generate your differential. Again, the hyperdensity on CT is something that's been timeless but holds. It suggests hypercellularity, dark T2 signal correlates with ADC signal being low, and whether it's in the pineal area or supratentorial area, and a supratentorial PNET. Rim calcifications are classic for craniopharyngiomas. Supratentorial PNET does have worse prognosis than medulla. I knew I would forget to tell you this, so I put it there. Advanced MR imaging tools can be useful. I suggest that you get comfortable with using a few. I definitely will, for treatment cases, will do a combination of perfusion, diffusion, and spectroscopy. But the key thing is to get comfortable with whatever you're using and be consistent. And then I talked about some of the molecular genetic correlations, especially the BRAF mutation is really a big thing now in low-grade tumors.